All right, my friends, welcome to another episode of Why I Didn't. In this episode, we're covering why I didn't go into anesthesiology. For those of you who are new here, this is a interesting series. I tell you my subjective, opinionated, biased experience of a certain specialty and why I ultimately did not choose it. You can think of this as the opposite of So You Want to Be on the Med School Insider channel. That is a very objective, comprehensive, unbiased overview. I work with 1 to 3 experts in the field for each video before we publish it. So it's really accurate, really unbiased, a really good overview. So if you want that, go check out So You Want to Be an Anesthesiologist. But if you want my mostly useless opinion, I mean, what do I know? I'm a plastic surgery residency dropout. If you want that, then you've come to the right place. But keep in mind, take everything here with a massive boulder of salt. Oh, and if you want some funky fresh merch, you can find that below this video. Members get an exclusive discount. Let's start with what I liked about anesthesiology. So first up is the lifestyle. Anesthesia has a pretty great lifestyle. If you actually look at the big popular physician bloggers, they're usually either anesthesiologists or emergency medicine doctors, and that's because both of those specialties give you a lot of flexibility and control over your schedule. You also don't have to take work home with you. So don't get me wrong, it's not always super relaxed and chill, because when things hit the fan, things definitely hit the fan. But for the most part, from my experience of viewing anesthesiologists as a medical student and as a resident, there's a lot of time where you're just kind of chilling, sitting in the OR and like monitoring the patient, but doing something else on the side. There were many times when I saw the resident or the attending anesthesiologist either playing Sudoku or reading blog posts or like typing emails and stuff, and not necessarily focusing 100% on the patient, which is fine because the patient was stable. And I love that aspect because you're able to do things on the side, maybe work on that little side gig, that side hustle while you're at work and while you're being productive, and you're still getting paid. It's a good deal. Even during anesthesia residency, it is a little bit more laid back, at least comparatively speaking. I remember at my program, I spoke to some anesthesia residents and they said they were working between 50 to 60 hours per week on average. Sometimes you have more, sometimes you have less, but that's pretty good in terms of residency hours. Number 2 is the occasional excitement. While it is mostly chill most of the time, you will occasionally have those critical moments, and then you'll be the one either stabilizing a critically ill patient or running a code blue. I've heard that it's roughly 85-15 or 90-10 of chill versus hitting the fan. And I really like that, where you can have a more chill pace most of the time with the occasional spikes of excitement, the occasional adrenaline rush. Whereas I feel that with emergency medicine, it was this baseline of frantic energy without any emergencies, and occasionally an emergency would come in, but even without that, when patients were more or less stable, there was kind of this, the way that I felt in the ED was a little bit of a frantic energy, and doing that day in and day out just wasn't as fun. I preferred the chill of anesthesia with the occasional spikes. Number 3, work doesn't come home with you. When you're off work, you're totally off. You don't need a pager, you don't need to be called in the middle of the night. And this is because anesthesia doesn't have their own primary patients. They don't own any patients. And of course there are exceptions, like if you were running a pain clinic, but for the most part, anesthesiologists are helping the primary service. Number 4, no clinic. There's 2 types of people in medicine, those who love clinic and those who hate clinic. And I was definitely the latter. I did not like clinic. Although I will admit, I probably didn't hate it as much as other people, but it still wasn't my favorite. One of the necessary evils with surgery is that for most surgical specialties, you need clinic. That's just the nature of pre-op planning, post-op management, things like that. But again, with anesthesia, there's no clinic because you don't own any of those patients, and I love that. Next up is the OR. The OR is like this magical place in the hospital. Each room is its own little microcosm, and there's a clearly delineated team that's working together on a singular case, a singular purpose. And while there may be pages or calls that interrupt the case from time to time, that's natural, the singular priority is still what's happening in the OR, and I like that. I find that because of this, in the OR, you have a certain level of camaraderie that's more difficult to find elsewhere in the hospital. Also, the OR is a little bit more relaxed when it comes to the whole social justice warrior cancel culture kind of nonsense, where you can play music that has profanity.
Oh my God.
I mean, assuming that the patient is under, not like while they're awake, obviously. I think overall, the OR just suits me better than other places in the hospital or clinic. So for example, organization and cleanliness is a top priority. That's very much me. There's an intense focus on a singular task, also very much me. And then of course, less social justice kind of vibe. But don't get me wrong, you'll occasionally have a charge nurse or a scrub nurse that gives you the stink eye because you're playing Dr. Dre or may report you for that. Next up is the focus on pharmacology and physiology. It's cool that you're able to nerd out on the pharmacology and physiology that you learned in med school, but in a lot of specialties you kind of forget. And being able to practice that day in and day out, I think it's cool. It's not a huge factor, not a huge draw, not a massive thing that really wowed me, but it's a nice little bonus. Next up is the more simple social work and limited charting. So this again comes down to the fact that anesthesiologists don't own the patients, they're helping other primary services. Your job is to speak to the patient beforehand, explain to them what you're gonna be doing, the role, what their experience is gonna be like, take care of them during the case, and then post-op, once they're stabilized, you're done. So if you get annoyed by a certain patient, no problem, you just put them under, and then when they wake up, they're someone else's problem. The biggest thing here though is that you don't have to deal with dispo or disposition issues, meaning when the patient is discharged, where do you send them? Sometimes you can have a patient delayed and they stay on the service, they stay in the hospital for much longer than medically necessary because they don't have a place to go. And then number two is the limited charting compared to other specialties. The dispo issues really vary by specialty. So like in plastic surgery, you don't really get much dispo issue compared to something like internal medicine, where it's very common. And it's just kind of frustrating as the provider. And then lastly is compensation. I think anesthesiologists are pretty well compensated. The average is $378,000 as of last year. So it's not the highest compensation, but it is in that top third. And you're not working as hard for the money in terms of, sure, an orthopedic surgeon, a neurosurgeon, a plastic surgeon are all gonna make more than the average anesthesiologist on average, but they're also working much more grueling hours, a much more challenging lifestyle. And with anesthesia, the balance of work to compensation is pretty good, possibly beaten by maybe derm, but very few specialties. Next up, what I did not like about anesthesiology and why I didn't choose it. First up, you're not doing surgery. You are in the OR, which is cool, but if you're in the OR as a physician, you have two options. Either you're the surgeon or you're the anesthesiologist. And if you love operating, which I did, then if I was an anesthesiologist, I would be just sitting there on the wrong side of the drapes, looking over, wondering, what if? Kind of what's going on? Man, I wish I was doing the case. The second thing I don't like about anesthesiology is that you're second in command, and I know that me saying this is gonna ruffle some feathers because it already did on the So You Want to Be an Anesthesiologist video, and some people in the comments were very angry. How dare you, we're not second in command, we're equal. But again, this is my experience, my opinion, what I've seen with my eyes, and we've already established that my opinion is worthless. And the patient is theirs, so to speak, the surgeons, and they're the captain of the ship. But don't get me wrong, anesthesiologists are mission critical to the surgery and the case won't proceed without them. But at the same time, it's all in service of the surgery and the surgeon is at the center of that. I've lost count of how many times I've seen a surgeon barking at or being really pissed and just disrespectful to an anesthesiologist for various things. Maybe the patient is moving in the middle of the case, which is, very dangerous, obviously, or the patient didn't go down under quick enough, or they weren't woken up quick enough, or who knows what else. And I remember being just so impressed by the calm reserve of these anesthesiologists who were being disrespected and kind of, yelled at. And I remember thinking that if I was in their shoes, it would be a lot harder for me. And at a certain point, after enough times being yelled at, I would just yell enough and yell at the surgeon and put that twat back in his place. Number three, procedures. I think a lot of people overstate the level of procedures with anesthesia because in my mind, a lot of the procedures are kind of, I mean, the cool thing is that you are doing more procedures than the average non-surgical specialty, than the average clinical specialty, if you will. But the procedures you're doing are things like placing oral and nasal gastric tubes or intubation or arterial lines or epidurals or mask ventilation. So overall, not the most exciting stuff, and it's overall a con for me. Next up is no continuity with patients, and I wasn't sure if this was a pro or a con because I can see both sides to it, but after further consideration, I think it's a slight con for me. The reason being that there were several patients that I did enjoy seeing and building relationships with. Not every patient, but a substantial portion of them. Usually as an anesthesiologist, you're seeing the patient pre-op, and then intra-op, and then post-op, and then you're done with them. And unless you're doing something like a chronic pain clinic, you're not really seeing them longitudinally over longer periods of time. And I would never open up a chronic pain clinic because I've just heard from colleagues that it's a difficult patient population to work with and it just wouldn't be my cup of tea. Next up is the moderate risk of burnout. And this one actually surprised me. I would have expected anesthesiologists to have a lower rate of burnout, but it's actually more middle of the pack. According to the Medscape 2022 report, anesthesiologists were at 47%, whereas emergency medicine was at the very top at 60%, and then at the bottom we had public health and preventive medicine at 26%. But even in prior years, before the pandemic, anesthesiology was always middle of the pack. It was actually at 42% back in 2019, and that year, plastic surgery was at 36%. Next up is that it didn't stroke my ego in the way I wanted it to be stroked. Anesthesiologists are usually the unsung heroes. They don't get the recognition that they actually deserve. When the patients are really grateful for a surgery going smoothly, they usually just thank the surgeon and then forget about the anesthesiologist. Anesthesia is better suited for those who have small egos, but because I'm so sensitive and delicate, I wanted a little bit of the glory. And the last point I don't like about anesthesiology is mid-level encroachment. Mid-level encroachment is a huge issue across many specialties in medicine, not just anesthesia, but anesthesia is at higher risk. It's crazy to me how some CRNAs will argue that they are equally qualified to anesthesiologists despite having a small fraction of the level of training. It's really Dunning-Kruger in full effect, where they learn a little bit of knowledge and they overestimate their level of expertise. But then as you learn more, then your perceived level of expertise, you realize how little you actually know. And that's why the Dunning-Kruger has that dip before it starts rising again when you are a true expert. And some of them are even lobbying to change the term from nurse anesthetist to nurse anesthesiologist, which is just like, it's just blurring the line to confuse patients. There's no utility in changing that name. But again, no hate against CRNAs as a whole. I'm just pointing to the minority who is really, embracing the whole Dunning-Kruger in full force. Because while CRNAs can handle maybe 75, 80% of what an anesthesiologist can, when things go sideways and hit the fan, you definitely want an MD anesthesiologist there, not a CRNA. But there are a few issues here. So one being that hospitals are now having an anesthesiologist oversee multiple CRNAs in different surgical suites, such that they can hire fewer anesthesiologists. So the overall demand for anesthesiologists could decrease. I think the direction that things are heading overall in medicine with med-level encroachment is very concerning, and it's a safety issue for patients. And once we have more data, some data is already coming out, we will realize that, yeah, these mid-levels who are less qualified and less trained than physicians, there are certain risks when they are practicing independently. So things will snap back eventually, but we're not there yet. And I think by the time that happens, a lot of the damage will already have been done. All right, so overall, here's what it came down to. If you love the OR and can't imagine doing anything else, become a surgeon. But if you like the OR and you're cool not necessarily having to wield the scalpel yourself, then anesthesia is a great fit. If you enjoyed this video, check out another specialty on my Why I Didn't playlist, or So You Want to Be an Anesthesiologist. Much love, and I'll see you guys there.